Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Gilead Sciences, Inc.
Welcome everyone to our session this afternoon. Very excited to be here. Today we will be talking about discussing key clinical decisions in managing PBC, primary biliary cholangitis. I'm your moderator, Maria Murray. I am a patient, a PBC patient. I'm also with the Canadian PBC Society as a patient advocate out of Toronto, Canada. I was diagnosed in 2019 with PBC when it was recognized that it actually was PBC. And then very quickly I became very, very ill with all the classic symptoms and then transplanted in 2021. I'm doing well today, and as you can see, I'm up here on stage and very proud to be representing PBC patients and patient voices and the Canadian PBC Society, and in partnership with our other patient advisory groups around the world. I would like to introduce our faculty. We've got Dr. Gideon Hirschfield, the Lily and Terry Horner Chair in Autoimmune Liver Disease Research, the Autoimmune and Rare Liver Disease Program at Toronto General Hospital in Toronto. Welcome.
Thank you very much.
And then as well, we have Dr. Sonal Kumar, Assistant Professor of Medicine, Weill Cornell Medical College out of New York. Welcome.
Thank you.
Today, we are going to address key clinical questions in PBC management through talking about assessing risk, setting treatment goals, and managing symptoms. And then our second part will be about discussing two case studies. One, incomplete response to UDCA, and one in combination therapy. So first, I wanted to send it over to Dr. Hirschfield, who will be talking about assessing risk of progression.
Thank you very much, Maria. And I'm thrilled to be here today to try and, enthuse you to really aim for the sky. We'll start with a case. This is, it's great to have Maria here. This is one of the first ever CME events where we've had a patient chair the actual session, because it's all about real people with real disease. So this is a 42-year-old woman who presents with fatigue, vague upper abdominal discomfort. There's a history of psoriasis, just topical therapy. Just makes you think about itch though, doesn't it? And look at those labs. Cholestatic liver test. ALP phos is more than 3 times the upper limit of normal. Gamma GT is elevated. There's an increase in ALT, but there's preserved normal liver function. So you're going to do some further tests. Partly based on your history, you're going to do simple imaging. You really don't need more than an ultrasound in PBC. It's very rare you need any more. And in this case, there's no gallstones, no normal liver and bile ducts, and I'm always looking at spleen size when I get the first ultrasound in one of my patients. And then you're going to do your so-called non-invasive liver screen to make a clear diagnosis. And when you do that in this patient, it's what you expect. She doesn't have any other risk factors for liver disease, and therefore, by pretest probabilities, you're actually expecting this to be PBC, and it is. The AMA is high titer, 1 in 320, completely clear. ANA is positive. Remember, 50% of patients will have a positive ANA. IgM is elevated, which is sensitive but not specific for PBC, and IgG is normal. And with that, it's so key, you can tell this patient in your office a very clear diagnosis of PBC has been made. Cholestatic serum level test plus AMA positivity gives you more than a 95% positive predictive value that if you biopsied the patient that there'd be PBC. So the journey has begun for this patient in making a difference to her life by choosing the right therapies and managing quality of life as well. What concerns you most when assessing risk for progression in a patient with newly diagnosed primary biliary cholangitis? Age at diagnosis, ALP, bilirubin, FibroScan as evident by FibroScan, for example, severity of symptoms. Okay, so a good spread actually, so what you are reflecting is the fact that in fact outcome for our patient is a matrix. It's a matrix of many things that determine why they got PBC, the risk for their PBC without treatment, and then their prediction from their response to treatments, both for disease progression and for symptoms. And you've always got to do this when you see a patient with PBC. It's the same as when you see a patient with IBD, when you see a patient with Hep C or Hep B. Think about the patient in front of you, okay? So use risk stratification in your approach to management by saying to yourself, what do I see today? Some of which is what you see, some of it is what you measure. Age, sex, comorbidities, disease symptoms, presence of fibrosis. And these are key themes to help you understand risk stratification for the journey for your patient and the pace with which you need to do things to reach for the sky, as I said, and aim for optimal care. And individual patients, of course, have different needs. And that's actually why we're so excited in 2024, that we will have so much choice this year, next year, and beyond. And if you think about the different needs of our patients, that's how you can then frame their individualized care. Do they respond well to UDCA? Are they very ductopenic? Is there more scarring? Is there more inflammation? What about cirrhosis? That's what we want to prevent as a hepatologist, but we still have to look after patients with cirrhosis, and 25% of the patients that come to our clinic have cirrhosis. Diversity, age, sex, what does their autoantibodies look like? Have they got other autoimmune diseases? So phenotypic stratification is vital to identify subgroups of patients with distinct disease prognosis. Because again, our job is if we identify that, we can make a difference and we can change their prognosis. Things are not predetermined. We can make a difference. And then I like to sort of think about how I put the patients into different sort of risk categories. Every patient with PBC should be considered for best care, but some patients are on the average risk and have got lower risk PBC and require less intensive care. Some patients on the right need to be, escalated through the pathway and need to move from your office to hepatology to tertiary centers because they've got advanced disease and they're heading towards liver transplant, or you immediately can't manage their symptoms, and that's an emergency for them. And then there's the group in the middle, so-called intermediate to high risk, age, slightly higher ALK phos, bilirubin, low albumin, and advanced fibrosis or cirrhosis.
But I have a question, Dr. Hirschfield.
Good.
So based on the case study that you presented, this patient's risk at baseline, what would you do next in their care?
You must never be ageist in medicine, okay, because we're looking for our patients to get, all the way into their 90s and 100s. But this patient entered my office under the age of 50, and 50% of patients diagnosed with PBC under the age of 50 will not get sufficient response to UDCA. And I know that before she's walked in the door, okay? So, that to me stands out. And what that means is I tell her a clear diagnosis, I tell her I can make a difference, and I start her on the journey, which remains to be starting with ursodeoxycholic acid, bile acid pool modification, and I tell her I'm going to watch her. I'm going to watch very carefully, and I'm going to be aiming for the best I can do for her, and the best, in theory, I can do for her is no symptoms and normal tests. And I tell her that I'm going to keep a close eye on her, and I'm going to respond to her response. So actually, look, the slide says what I just said. That's great, okay? So having done that, I got the answer right. Having done that, okay, we're going to treat. We give UDCA as a weight-based therapy because it's a bile acid pool modifier. You know, we kind of know by our practice over the last 30 years, 13 to 15 milligrams per kilogram is the correct dose per day, okay? And then with that patient profile, you're going to think, am I going to see them maybe once a year? Obviously, the first few times you see a patient, you see them a bit more to do patient education, make sure they're connected with the patient support groups, and you know you've done everything. But eventually, they may only be once a year getting on with their life. Okay. Someone in the middle, like the patient I described, I'm probably going to be seeing more often, you know, no more than waiting 6 months. And then for the sick patients need to be seen as often as they need to be seen. I tell my patients, if you need to be seen weekly, I'll see you weekly, okay? But I mean, we're good at that as physicians, and we will, you know, adjust to the need. And then, you know, with continual follow-up, we will refine what that patient needs.
Okay.
And there you go, that's our patient. I've started the treatment. I've made sure she can contact us. Many of you in the room will have Epic, so they'll send me a patient message, okay, through Epic to tell me that they could pick up their urso, you know, and that they're tolerating it all right. And that way I'll probably be able to see them at 6 months because I've already got some digital communication, you know, essentially like a live SMS into my inbox. Okay.
All right, thank you, Dr. Hirschfield. So I'm going to continue this conversation with setting treatment goals. So we have another polling question. What is your primary treatment goal when seeing a patient with PBC? Number 1, avoidance of transplantation. Number 2, resolution of symptoms. Number 3, alk phos normalization. And number 4, normal bilirubin. All right, so again, all spread out pretty evenly amongst avoidance of transplantation, resolution of symptoms, alk phos normalization, and a few of you also said normal bilirubin. And I think this is completely reasonable. And you know, ideally we want to do all of these things for our patients, but what you really focus on may depend on what patient is in front of you when you see them in a clinic. So if you see a patient with who's young, like we talked about with the previous patient, and they already have a liver stiffness measurement of 12 and an alk phos level that's 1.3 times the upper limit of normal, when they come to you and they present to you, you're considering this patient to be of higher risk. And we want to shoot for the sky for this patient, and we want to try and improve their long-term outcome. So this is someone who you may consider complete normalization of their labs to be the primary goal for treatment. Whereas if you have a 68-year-old patient, no evidence of significant fibrosis on liver stiffness when they come into your clinic, or even after starting therapy, and the alk phos level is 1.3 times the upper limit of normal, then you can talk to your patient about what are the options about, you know, add-on therapy. You need to balance the benefit risk of using second-line therapy. And then when you have a non-responder to UDCA, so someone comes into your clinic, they've been on UDCA for 1 year, 2 years, 3 years, you establish that they may need second-line therapy, then we have to go down the algorithm of which second-line therapy we want to start in these patients. And some considerations, if they don't have any itching, you can use obeticholic acid, you could use one of the PPARs that were approved. If they have pruritus, probably steer towards the PPARs. If they have evidence of portal hypertension, also steer towards the PPARs. But really the patient profile, who is sitting in your clinic ahead of you, really determines what your treatment goals are and what your next steps should be. And you know, the theme of this entire discussion really is individualized care. So if you look at the prior algorithms of how we used to manage patients with PBC, we start with a diagnosis, which is pretty standard, and then you would start someone on UDCA, the weight-based dosing, and then you wait 12 months. You give them a year of UDCA, see how they respond, and then after that year, you can consider second-line therapy and manage their symptoms. But what we're learning now is that managing PBC is not a one-size-fits-all kind of paradigm that we should be using. And we really should be moving towards personalized care and target our therapy according to each individual patient. We want to look at liver tests. We want to look at their baseline fibrosis. We want to look at their symptoms. We want to look at other risk factors such as age, and then treat them based on that risk profile and how they respond to that treatment. And then, of course, we can have some aspirational goals as well, that patients fully are aware of what their risk is about their disease course. We can aspire to get normal serum liver tests in all of our patients. If ductopenia and liver fibrosis resolved, if they were to get a liver biopsy, we of course want to impact quality of life, avoid liver transplantation, and then eventually hope for a cure with PBC. And why do we want to, affect the disease progression? Because this is not an indolent disease. So if you actually look at the disease course of patients with PBC, this is something that can progress relatively quickly. So looking at 10 years, about 40% of patients with PBC will have developed cirrhosis. So although we had this big name change from changing from primary biliary cirrhosis to cholangitis, it doesn't mean that patients can't get cirrhosis, and it doesn't mean that they can't get cirrhosis in a short amount of time. And this holds true especially if they're inadequately treated. So this is an older study, I think from 2002, that looked at patients from 1987 to 1994. And these are patients that, this was before we were consistently using UDCA in our patient population. So there were 770 patients. They were followed for 7.4 years. And I think about a third of them were on UDCA. And deaths during follow-up were 417. So patients that are inadequately treated do have a high risk of disease progression. They have a high mortality risk as well. So when we think about our treatment goals, big picture treatment goals for all of our patients, we want to prevent cirrhosis, we want our patients to maintain their liver function, and then we want to really focus on quality of life as well.
So one of the things that comes to mind is liver biopsy. So, like as a patient that progressed quite quickly in my disease, I was always curious why I didn't have a liver biopsy, but a lot of other PBC patients did. And I always wanted to see what my liver looked like. Like, how do I know that it's cirrhotic, right? Because I had the pruritus, I had the extreme fatigue, I had major ascites, portal hypertension, the esophageal varices over 5 months that I had ligations. When is biopsy, is it a practice? When do you decide to have one or not in clinic?
Yeah, I mean, I think we've moved away from doing a lot of liver biopsies. We know the majority of patients can be diagnosed just with an elevated alkaline phosphatase and positive AMA. So for diagnosis, we don't do a ton of liver biopsies anymore. I think they still play a role when the diagnosis is in question, when you're looking for other diseases that may contribute to this. That's when I would consider doing a liver biopsy. I don't know.
No, I totally agree. I mean, remember, the question about liver biopsy, has to be beyond, I would love to look at, PBC under the microscope, but, if it doesn't help the patient, if I know you've got cirrhosis, I can see the consequences of the disease, it's an unnecessary risk, okay? So there are times to do, if people might have fatty liver, etc. So, but it's selected.
Just very curious about that, and I think as things progress, we get better and better at looking at those markers and not needing to put patients through unnecessary treatments or procedures like that. Which then, in terms of our treatment goals for patients, so should normalization of ALP and bilirubin be that goal?
Yeah, I mean, I think in an ideal world, it would be great to normalize patients' alk phos and bilirubin. And a lot of that comes from the data that we have on what happens when your alkaline phosphatase and bilirubin are not normal. So here you can see on this graph that the top line are patients with an alk phos level that's within normal limits. And then even a little bit increase in the alk phos above the upper limit of normal affects your survival curve. So the blue line are the patients with an alk phos level from 1 to 1.8 1.67 times the upper limit of normal, and then the red line on the bottom is 1.67 to 3 times the upper limit of normal. And what you can see is that the 1 to 1.67 patients are closer to the patients with an alk phos level of 1.67 to 3 times the upper limit of normal. So I think this really is very convincing data, and there are other studies that have looked at this as well that show that we really should strive to flatten that survival curve as much as possible, and that involves normalizing alkaline phosphatase. But not only alk phos, bilirubin as well. And here there are dramatic differences when the bilirubin is above the normal range. That's the curve on the right. But not only do we want to strive for having a bilirubin that's within the normal range, it's 0.6 times the upper limit of normal that was shown to be the cutoff for affecting survival. And that's sometimes really hard because when we look at labs, we look at normal versus abnormal, but I always try to convey to anyone I may be teaching, or even in my own patients when I'm looking at them, if you start to see the bilirubin climb, even in the normal range, that is, that should be a red flag that patient's the disease may be progressing, and you have to pay attention to that. So really, I think we should strive for everyone, ideally, to get that alk phos to be normal and get the bilirubin not only to be normal, but less than 0.6 times the upper limit of normal. But I do think, that there are certain patients that we really need to push extra hard for. And so this has also been looked at. Who are the highest risk patients? Who are the ones we really, really, really need to get the alk phos normalized, and who's going to benefit the most in terms of long-term survival? And what we found is that patients with advanced fibrosis with a liver stiffness measurement of 10 or above, 10 kilopascals or above, and age greater or less than 62, those are the patients that are going to benefit the most from having normalization of their labs. And the group of patients that this study is referring to, the estimated gain in survival was 53 months compared to patients without those characteristics. So I think, yes, I do think we should strive for everyone, but especially in these high-risk patients who already have baseline fibrosis scores, and those that are younger as well. And this goes along with what we've been talking about with this case that we started off with. She was young and already has elevated stiffness.
So then that leads us to how should clinicians work with their patients to set treatment goals? So you've got treatment goals from a clinical practice and guidelines that you follow. But then you've got a patient in front of you that might be emotional, might have physical limitations, social impacts, quality of life is impacted, and just someone who is anxious and depressed, and like all of the things that I certainly went through, and I wanted more out of my care. I wanted to feel like I was productive, and to tell me about my blood work is one thing, but it just didn't change my quality of life. So how should you incorporate into the treatment package to deal with patients in a more holistic way?
Yeah, I think that's a very important point, and it's provided, I just spent this whole 10 minutes, 20 minutes talking about normalizing your alk phos, avoiding liver transplant, flattening your survival curve, but you're the one who has to deal with this on a day-to-day basis. And that's where I think, we're switching hopefully to more personalized care, and quality of life is part of that. And we have to discuss with you as a patient what your quality of life is. What is your goal? And address it accordingly.
No,
Dr. Hirschfeld?
Totally agree, and we have to tell ourselves every time we go into clinic, to listen. So it's a bit like screaming at your children and telling them to listen, and but you just have to keep saying it, okay? Because if you listen, and you can't do everything on every clinic visit, and some clinic visits are quicker, some are longer, you'll hear all those things that you just said. And my experience has been that patients are very reasonable people. We're all going to be a patient at some point. And as long as they feel they're being listened to, and you've told them what you can do, what you might be able to do, what you can't do, and what they can do, and what they can do to help themselves without your help, that actually is a recipe for success. I don't find that our patients have unrealistic sort of expectations of us, but they do leave the room, like you said, disappointed if they didn't feel they were spoken to and listened to, and given suggestions or empathy. So really important.
So when you first have that appointment with that patient, are you on the computer and you're looking up all the labs and the patient's sitting there like all...
I'm not just on my computer, I've got my phone open at the same time. Of course we are. I mean, look, you're not going to get the perfect world.
So you've got 6 minutes to see me. What's your first thing that you're going to tell me?
Well, actually, I would rephrase that. What we're actually spending time is we're teaching our patients to come into the room with a series of questions as well, so that the patient does a bit of prep before they go to see their doctor for whatever they're doing, and has already stratified, my priorities leaving the room are going to be these 3 things. I want to know, what do I have, what's going to happen to me, and what are you going to do about it? But what I'm trying to do is exactly what you just heard, is have a clear diagnosis, tell them where they sit in terms of risk, and tell them their options, okay, and tell them their choices, and tell them what I think will work, and then listen to what they say is their prioritization. And I always tell my patients, I'll never fire you if you don't take my advice, but I will tell you if something that you're doing is bonkers, okay, but I will still look after you, okay? So that at the end of the day, they're empowered to make the decisions that work for them.
So I think it's a mutual communication and respect, and I can appreciate having all their questions as a patient ahead of time so that there's focus.
Where next? Oh, back to me.
You're up.
Okay, so
Yeah.
we're going to move on, and keeping the theme, we're going to be addressing key clinical questions in management, and particularly around the symptom profile of primary biliary cholangitis. What symptoms related to PBC do your patients find most debilitating at diagnosis? Fatigue, pruritus, abdominal discomfort, something else, or none? The patients you see don't have any symptoms. Let's see. So, I think that's reflective of good care amongst the people who've come today, is that, in fact, 50% of our patients have a very good quality of life, but even still, if you talk to our patients, most patients have got some symptoms, whether they are definitely PBC specific, but fatigue, pruritus, and abdominal discomfort is actually quite impactful for people living with PBC.
I think that's consistent with some of the symptoms I had initially, but what rated low there was abdominal discomfort, and that was my primary issue. And so I was seeing a gastroenterologist for that, and then so I kind of went back route. And then the fatigue started, and I think it depends on the patient. We're all unique, experiencing at different times. I understand that there's not necessarily a correlation of stage and symptom. Is that?
Absolutely. I mean, so clearly the sicker you are, the more symptoms you have, but you can have pretty good tests and still be symptomatic, because we don't really understand how the brain is sensing all this inflammation. And some of this inflammation is low level and is being sensed as the cholestasis, the bile acids entering in the systemic circulation. Some of the symptoms actually probably include physical. So, if you're teaching a medical student about cholestatic liver disease, you'll teach them on examination that a patient with cholestatic liver disease may have a big liver. Okay, that's not an infrequent clinical observation in overt cholestatic icteric liver disease. And actually, I suspect some, change in liver size might relate to abdominal discomfort, where pruritus is much more closely linked to the disease biology, and fatigue, we don't understand what it is that the brain is sensing to scramble up the signals in the cerebral cortex to make people feel fatigued. But they're impactful, they're there, and they're frequent, and they reduce health-related quality of life. And as you pointed out, that's what matters as you leave the door. Now, we do want to be diagnosing people early, and when we do pick up people early because they've been screened by very good primary health care physicians or nurse practitioners, then of course at very early disease we may be lucky and they may well be asymptomatic. And in fact, of course we'd like to capture our patients as early as possible because that's the moment in time that we're probably going to make the biggest difference for changing the natural history. And treatment goals therefore will include listening, appreciating the symptoms, and improving health-related quality of life. This is a very representative survey. We could go around the world and, just to reiterate, all patients, wherever you live with PBC, if you do the surveys in their native language, will describe the same pattern of symptoms with some variation. But this is a Dutch survey, 178 patients using a validated tool, the PBC-40, and you can see the impact of, a number of domains which are scoring higher than they should on average, including itch and fatigue. And for some people, it's severe enough and it's definitely impacting their quality of life. So I'll hand over now, and we're going to have to case.
All right, so let's go to some cases. So this is the first one, 53-year-old female patient. She has low vitamin D level, elevated cholesterol. She was initially seen in clinic because she had a positive AMA and elevated alkaline phosphatase. So when she first comes into the clinic, already we can give her a diagnosis of PBC because she meets those two criteria. Her initial alkaline phosphatase was 390, ALT 82, AST 78, and total bilirubin of 0.4. And it's not atypical to see some elevation in transaminases when patients come in with PBC. Overall, from a symptom standpoint, mild nighttime pruritus, no treatment required, and her FibroScan score was 6.4 kilopascals. So she was appropriately started on UDCA and then had follow-up labs at 1 year where she had some improvement in her alk phos level, went from 390 to 272, AST and ALT got a little bit better, T-bilirubin is 0.6. The discussion was had about starting a beta-cholic acid. She was concerned about the risk of pruritus. We always want to discuss potential side effects, however mild or severe they may be, but she ended up starting it and alk phos levels stayed about the same. So then, thinking about second-line therapy, so she was already started on an FXR agonist. She was started on a beta-cholic acid, but when we think about, in general, someone who may be a candidate for second-line therapy, there's 3 categories of medications that we think about. The FXR agonist, a beta-cholic acid, that was approved back in 2016. More recently, PPAR agonists, elafibranor and seladelpar were approved this year. And then the fibrates, bezafibrate not available in the US, but some people do use fenofibrate off-label for second-line treatment. And then if you think about how these medications work, there's sort of 4 different categories. They downregulate bile acid synthesis, decrease cholesterol synthesis, downregulate CYP7A1. They also induce bile acid and phospholipid secretion, improve bicarbonate secretion. So the bicarbonate is thought to be protective from the toxic metabolites and protect the biliary epithelium. There are some anti-inflammatory effects that we see with these medications, and then anti-fibrotic effects as well. But if you just think about big picture, decrease in bile acids, anti-inflammatory, anti-fibrotic, and increased lipid metabolism. So let's go through some of the data on what led to the approval of these medications. So first we'll start off with the beta-cholic acid. You may be familiar with the POISE trial. This was a placebo-controlled phase 3 trial that got approved, that led to the approval for a beta-cholic acid. Patients were included if they had an alkaline phosphatase level that was greater than 1.67 times the upper limit of normal, or an abnormal bilirubin, but it had to be less than 2 times the upper limit of normal. And they had to be on UDCA or intolerant of that. Now, they had a primary composite endpoint, and you'll see this composite endpoint throughout the rest of the other studies that we'll talk about, because it's become accepted as a valid endpoint that we can use to assess for treatment response. So alk phos level less than 1.67 times upper limit of normal, a decrease in alk phos of at least 15%, and normalizing the bilirubin. And you can see the graph on the right. So with the POISE trial, there was the one-year study, and then they had a 5-year open label extension. The primary endpoint, 46 to 47% compared to 10% in the placebo arm. The one thing with obeticholic acid is that pruritus was more common, 56 or 68% compared with placebo, which was 38%. And then ultimately, we talk about these goals of normalization and reducing bilirubin and having our alk phos go down, but ultimately we want to prevent outcomes, bad outcomes in our patients. So we need to see if this actually is impactful on liver-related outcomes, on survival. And so this is looking at comparing the POISE data, the POISE trial, so the open label, the 1-year trial, and then the open label extension, to external controls. So there were 2 groups of external controls. There was the global PBC group and the UK PBC group. And patients had to have had up to 5 years of OCA treatment in the open label extension, and then they were compared to that external control group. And what they found was that the primary endpoint was liver failure, liver transplant, or death, and this data supported evidence that obeticholic acid does improve transplant-free survival. So again, thinking from a liver standpoint, what are ultimate treatment goals? What are those endpoints that we really want to affect? There is evidence that obeticholic acid has an impact. The next medication that we'll talk about is seladelpar. So seladelpar is PPAR delta. This was the response study. So similar to the POISE trial, it was placebo-controlled. Patients had to have an alk phos level of at least 1.67 times the upper limit of normal. They had to either have inadequate response or intolerance to UDCA. Bilirubin had to be less than 2 times, up to 2 times the upper limit of normal, and they did allow patients with compensated cirrhosis. So they did some additional analysis. They had more stratification factors, such as alk phos less than 350 versus above or equal to 350, and then they looked at pruritus as well. Patients were separated from NRS score less than 4 to 4 and above, and then the 4 and above was thought to be patients who have clinically significant pruritus at baseline. And they have that same POISE endpoint, so the composite score, and then their key secondary endpoints were alk phos normalization at month 12 and change in pruritus at month 6 with patients with baseline pruritus. So here we can see the treatment difference. So in the treatment arm, there was 61.7% of patients that met that composite endpoint compared to 20% in placebo, with a treatment difference of almost 42%. And then here, this is just looking at alk phos change from baseline. So this is not the composite endpoint, just looking at the alk phos levels. And you can see, I think what's really nice about these medications is that you see a really early response. And so you kind of know if patients are going to respond right away. So by month 1, you already see this dramatic drop in alk phos levels, and then it's sustained over the 12 months. And then just looking at the alk phos differences, the treatment difference between placebo and the treatment group was 38%. And then normalization. So this was a key secondary endpoint in this clinical trial. Again, we want to strive to get as low as possible and normalize alk phos if we can in our patients. So I think this is really important. 25% of patients had normalization, so 1 in 4 patients treated with seladelpar did normalize their alk phos compared to no one in placebo. And then this is the pruritus. So, we're again looking at symptoms. We're recognizing the importance of symptoms and quality of life in our patients. So looking at the change in pruritus NRS scores, again, these are the patients that had baseline pruritus. And you can see that there was a change in pruritus over time, and this was statistically significant in the treatment arm compared to the placebo arm. The adverse events, you can see the list here. I'm not going to go through this whole list, but just to broadly speak, it was similar in the seladelpar group to the placebo group. 7% with a serious AE compared to 6.2% in the placebo arm. And then the discontinuation rates, which I think are really important, really tell you a lot of information. It was very low, 3.1% in seladelpar and 4.6% in the placebo arm. So then the ELATIVE trial, this was for elafibranor, which is a PPAR alpha and delta. Similar style trial, double-blind, placebo-controlled, and they also have an open-label extension. In their inclusion and criteria, these are similar across all of these trials. Alk Phos level greater than 1.67 times the upper limit of normal, and T bilirubin less than 2 times the upper limit of normal. They also stratified their patients, Alk Phos level greater than 3 times the upper limit of normal, or T-bili that was not normal, yes or no. And then they looked at the NRS score as well in these patients. And their key secondary endpoints were normalization of Alk Phos at week 52, and then change in pruritus intensity from baseline through weeks 24 and 52. And then again, their primary endpoint was the same POISE composite endpoint that we see throughout. So here's the primary endpoint result, again looking at that composite score, 51% in the elafibranor group compared to 4% in the placebo arm, with a treatment difference of 47%. And looking at normalization of alkaline phosphatase, here you can see 15% in the treatment arm compared to 0% in placebo. And then again, we're seeing a very dramatic drop in alkaline phosphatase early on, and that is sustained throughout the 52 weeks of the trial, with a treatment difference of 41% between elafibranor and placebo. So when it comes to pruritus, investigators also looked at pruritus, and what they found among patients with moderate to severe pruritus, changes in the PBC worst itch NRS score did not reach statistical significance through week 52. They did see a significant improvement in PBC 40 itch and the 5D itch scores compared to placebo, though. And here, again, low adverse events, so it was 96% in elafibranor, 91% in the placebo. Severe was 11% across both arms. And then discontinuation rate, also low. Elafibranor was 10% and placebo was 9%. And you can see most of the side adverse events here were GI related. All right, so when we think about the PPARs, they were all approved in the last year. I think one of the, comparing this to what we've had in the past, I sort of mentioned this, but one of the nice things about the PPARs, I think, is that it really takes into account the quality of life of our patients. It has an impact on itching. It can improve itching, has a favorable effect on lipids. We didn't show the lipid data here, but it also has a favorable effect on lipids and an impact on improvement and normalization of Alk Phos levels. All right, so when should patients be considered for second-line therapy? I think, this is a really important question. When we talk about the initial algorithm for managing PBC, we talked about waiting those 12 months before assessing when patients have a response to UDCA, to assess whether they have that response at that 12-month mark. But I think, as providers, correct me if I'm wrong, but we kind of have an idea if a patient is going to respond to UDCA, if they're going to get to our treatment goal well before the 12-month mark. And so this was a study from the Global PBC Study Group that looked at just that can we assess response to first-line therapy at a sooner time point than the 12-month mark. And so they looked at they looked at the Alk Phos level at the 6-month mark and used the POISE criteria to determine response to treatment, and found that 1.9 times the upper limit of normal was sort of the magic number where you could assess at 6 months. If patients had not reached that 1.9 times the upper limit of normal response to UDCA in terms of alkaline phosphatase, they're most likely not going to have a response, complete response at the 12-month mark, using the POISE criteria as your goal. So this raises the idea that maybe we should throw out that 12-month mark, and especially in certain patients, we should consider assessing for response at the 6-month time point instead. And again, this just goes back to everything has to be really individualized, and we have to take the patient in front of us at hand, not just global recommendations. And the reason why we obviously don't want to delay second-line therapy is that we want to control the disease as soon as possible. Non-responses is associated with the destruction of bile ducts. Once you lose those bile ducts, they're gone, lead to ductopenia and cholestasis. Non-response is associated with progression of fibrosis, and obviously we don't want that to happen in our patients. And patients with more severe cholestasis or advanced fibrosis are less likely to respond to treatment. So if we can intervene sooner, if we can impact the disease course sooner in our patient population, why should we not do that?
Mm-hmm. Dr. Kumar, I have a question before we go to case 2 that's come in. Are there circumstances where you would discontinue ursodiol in patients with inadequate biochemical response before moving to second-line therapy? For example, a patient with limited or no ALP improvement.
I think you still get some benefit from being on UDCA. Even if you get a little benefit, I would probably keep the patient on. Again, these are all different mechanisms of action, and so I think keeping a patient, diluting the bile acid pool with UDCA is still important. And I would probably keep a patient, especially if they're not having any symptoms and tolerating it well.
Thank you. Okay, Dr. Hirschfield, I think we're headed to case 2. And
let me tell you about this patient. So 35-year-old young woman, please see abnormal liver test query cause, but also with severe pruritus. Ongoing, had many dermatology opinions, and a complex symptom complex, including sicca, fatigue, brain fog. The inability to do the Times crossword puzzle. Okay, multiple prior investigations overseas, and the patient has a diagnosis, but not clarity as to why they're looking cirrhotic. And, this is what her panel of tests look like. She has cirrhosis, and you can see that from the blood work. So remember what I said, this is a young patient, so my radar's already beeping at me, okay? And then I look at the bloods, to be very American, T-Billy is 1.7, okay, so that's elevated, that's not good, okay, Eldman's low, Alt-Phos elevated, thrombocytopenia, that great test for any hepatologist, that's the first thing we look at actually is the CBC, elevated liver stiffness, and she brings me the report that says there's varices, and an elevated IgM. So I'm already thinking to myself, although it's unusual for her age, this is likely to be an immune-mediated cholestatic liver disease. And then I send off the panel, and if you look on the left, you might get confused with the diagnosis. The AMA by immunofluorescence is negative, but she's centromere positive. So remember, you can get anticentromeres both in systemic sclerosis, but also in primary biliary cholangitis. You look on the right, if you have access, and I think these panels are available in the US, okay, to an extended autoimmune panel, there's a low titer AMA, so this is not in fact AMA negative PBC, it's AMA positive, just low titer, and she's got some of the more classical AMA negative PBC serology, SP100 and anti-PML. So, importantly, PBC is confirmed. That's very important. So the journey has begun. The clock is ticking to choose the right therapy for this patient to adjust symptoms and severity and outcome. So what do I do? Okay, this was a case obviously managed in Canada. I use UDCA. I can't use obeticholic acid because it's important I use drugs safely, and she has clinically significant portal hypertension, and that would be outside the label, okay? But I can very cautiously, and I'll be clear, very cautiously use a PPAR, because in fact, the labels, certainly in the US, you wouldn't use a PPAR, a licensed PPAR in someone with Charles Pugh B or C liver disease. I've got some symptom control, and I've got cirrhosis care. And I'll point out that I did use PPARs cautiously, and there was a little bit of decompensation which I needed to manage using my cirrhosis care. Plus, if I was thinking ahead, okay, and thinking to the future of PBC care, there are actually treatments coming which will, if the evidence is supported by clinical trials, that IBAT inhibition can be a very appropriate treatment for pruritus. And remember, this poor young woman has excoriations and has severe pruritus. Now, what's frustrating in this case is, in fact, she's a responder to treatment. But because there's been a delayed diagnosis, a lower awareness that this might be PBC despite her young age, she's missed the chance to prevent end-stage liver disease. And had I seen her at the very early stage of disease and been sequential in my approach to care and aspirational, aiming for the sky, as I said, look how well she responds to, in this case, dual therapy to ALK-Phos, gamma-GT, ALT, and pruritus. And increasingly we're getting better at actually documenting pruritus in a numerical scale like in clinical trials, because the reason it's helpful is you ask the patient, okay, but actually if you can start to get some numerical numbers in your notes, you can then look back over time and you can sort of see what happened. Even though you have a global sense they got better, having some numbers is actually quite useful from a management perspective. So Maria, you're the patient, what's your perspective on, some of the things I just sort of spoke about?
Right, so you talked about response to treatment. So I was diagnosed in 2019. I did have symptoms before that, markedly in 2017 with what ended up to be a gallbladder removal for a lot of discomfort in the abdomen. And that's where a lot of my symptoms started. And that wasn't the answer. That was, that's what kicked off that diagnosis then in 2019, and immediately was put on ursodiol, which, I think was probably a very good thing, but I progressed very quickly with other symptoms. So whether you call me a non-responder or
a very young woman.
A very young woman. I'm 55 right now, so didn't know what was going on. I was very good at taking my medication, but we didn't see any improvements, and in fact, more symptoms came on, and more medication, diuretics, rifampin, cholestyramine, which was, horrible to take, and nothing seemed to be effective. And second-line treatment was not an option for me, as I understood that it was not going to, I was already cirrhotic, and in that case, that would not be a course of action. Yeah?
Yeah.
So, my symptoms and treatment, in the end, were managing what I had, and the only resolution became transplant. I did have very severe ascites as well and hepatic encephalopathy. So, I think at that point it becomes a lot of follow-up and encouragement and just daily management to deal with what I had. The pruritus was still, uncontrollable. And I wish I had additional medications at that time. So I think, for patients like myself, it's really important to have availability in, I'm obviously from Canada, and other countries have access at different points. So I think as global an interest in PBC that we all work together to create the best possible outcomes for patients. So, being on the other side of transplant, it is very effective, immediately effective, but that's not what we want for our patients. We want to live well, right? And survive as long as we can and not die from PBC or other associations or comorbidities.
Yeah, and so you're describing the heterogeneity of PBC, and in some patients what you see is, this more potent attack on the biliary epithelium and more potent ductopenia and a much more rapid progression. But we still believe, broadly speaking, that if the more patients that we pick up at the earlier stages of disease and we intervene in a more sequential manner, the more patients will prevent from needing liver transplantation, which is phenomenal. But as you say, it's a phenomenal thing that you'd rather have never had to have.
Mm-hmm.
So,
let's look forward.
Yeah, let's look forward, and we will have time for some more questions. And, what we've said is, that to reach for the sky, you've got to climb, a pyramid, and you've got to get to the top. And in the PBC pyramid of care for 2024, 25, and beyond, we are seeing the progress. We are seeing things change. We're learning. We're learning about new drugs. We're learning how to use them. We're learning who to use them in. We're learning when to use them. We're learning what opportunities they offer. And this is just, in fact, the pyramid of care for disease modification, not even symptoms, from UDCA, obeticholic acid, bezafibrate off-label, 2 new licensed therapies in the US, seladelpar and elafibranor, combination therapies. We are really, moving with some pace into a different kind of approach to the PBC. And we can confidently believe that the paradigm of care can change, and how we evaluate and the goals that we set collaboratively with our patients. And we don't have to stick with this wait to fail approach, which is old-fashioned. Diagnosis, UDCA, second-line therapy. We can move to this new paradigm of personalized care. Okay, we can focus in on, making a difference, and we can target therapies to individuals' needs, and we will not do everything with the drugs we have at the moment. We still need even more drugs and more choices, but we are making that progress into aspiration, into individualized care, into prioritization of disease modification and quality of life. So I think we can be confident that this journey is picking up pace.
With that, very insightful session today. Dr. Hirschfield, I really enjoy listening to the both perspectives, and lots to think about, lots of opportunities for PBC patients, and I really thank everybody for attending today. Great turnout. Thank you.
Thank you.